Hi guys, this is John Adamson, the Rehab Documentation Guru. Sorry for the strange angle, but I've got my phone resting a little bit lower than me, so I got this big body, small head. But anyway, Happy New Year to you, and thank you for those of you that are regularly watching my videos, and hopefully you're getting something out of the content. Today what I wanted to do is talk a little bit about the difference between medical and treatment diagnoses. A lot of electronic medical records requires a therapist in some shape or form to enter diagnosis codes. And the typical scenario is obviously getting a prescription from the doctor with a diagnosis, or getting a referral, depending on the agency you work for a patient who's admitted to the agency with certain diagnoses. And I mean, a general rule of thumb is always going to be that those diagnoses will represent your medical diagnoses. So these are things, if you, basic summary of what this is, these are things that a medical professional can treat that do not require a therapist to intervene. So if you've got a patient with pneumonia, obviously as a therapist, I don't directly treat that. I treat the things that arise from pneumonia, like generalized muscle weakness, shortness of breath, difficulty walking. There are things that I can treat that are a result of the pneumonia. So a general rule of thumb is your referral source will be automatically giving you the medical diagnosis for one thing. But number two, when you look at the diagnoses codes, the ICD-10 code, you're going to be looking to see, is this something that I as a therapist within my scope of practice directly address, or do I indirectly address the things that happen because of it? Therefore, I've got treatment diagnoses. And that's basically it. Now, just to give you a little bit more information on medical and treatment diagnoses, the more medical diagnoses that a patient has, the more complex they are. And that's a good thing for the reviewer to see on a claim, is the amount of complexity based just on the diagnoses. A lot of third-party payers are making decisions related to payment based on the on the complexity of the patient, which is the only information they're getting is basically the ICD-10 codes on that claim. So if you have a single ICD-10 code on a claim and you're hoping that'll justify much therapy, you need to rethink that. Now, the other thing with medical diagnoses is you have to be able to prove that they're relevant. And in my course, Documentation Bootcamp, I talk a lot about relevancy. The big thing to keep in mind is that diagnoses cause underlying impairments. So things that you can measure as a therapist. And you had classes in school where you learned to do body systems assessment, like skin, muscle, joint, neurological. So think about the disease, think about the problems it causes with the different body systems, and then measure that stuff. Because all medical diagnoses on your claim should have relevance related to measurements. And if you cannot measure it, you cannot treat it. And that's a good axiom to keep in mind. As far as treatment diagnoses, again, you want to pick more than one if applicable. That's not always going to be applicable, but the more diagnostic codes you have, the more treatment the patient needs. And one diagnostic code I've covered in another video that should never stand alone is muscle weakness. So never ever use that by itself unless you've got a patient you think you're going to be done in just within a few visits and you're done. Because those claims are at high risk. We have seen in appeals management a lot of denials related to that diagnosis. So please make sure that you don't let that have that as a standalone diagnosis. And then other treatment diagnoses that you want to keep in mind that a lot of therapists use, for example, symbolic dysfunction is one that speech therapists use. Well, there are 4 criteria that are required to be measured to prove that. Let's see if I can remember off the top of my head right now, because I forgot to look it up just to refresh my mind. But acalculia, agraphia, agnosia, and apraxia. There, I got it. So one of those 4 items needs to be problematic if you're going to use symbolic dysfunctions. PT and OT, one code that I see a lot, that's used a lot, is other lack of coordination. And you better have good, solid, objective information, not only about the coordination itself, but its impact on functionality. And another one I see regularly used is abnormality of gait. And again, you've got to have good objective measurement of gait dysfunction if you're going to use that, because just walking distance and assistance level does not correlate with that diagnosis. And lastly, I would just mention abnormal posture. You got to be able to measure posture. There's lots of assessment tools you can get online that are easy to look up and help you objectify what's going on posturally. But again, you got to make sure you can prove there's a functional deficit related to that underlying impairment of postural deficits. So make sure you can correlate postural abnormalities with an actual functional problem. Otherwise, you can't treat it. Anyway, I hope that was somewhat helpful. Please feel free to leave in my comment section some information. Also, I'd really like to ask you a favor. I'm thinking about doing, coming up, we're still in the process of adopting, but coming up a live webinar where I would just be on YouTube answering questions. I'd pick a date and time, and I'd send a video just advertising the date and time, and then have you get online and ask me questions related to documentation. I think that would be really good. So if you think that'd be helpful, let me know, because I'd like to be able to get a sense of how many people might want to be on something like that. Anyway, this is John Adamson, the Rehab Documentation Guru. Please make sure you like and subscribe, and always, as always, remember, get paid for what you do. Have a great day. God bless.